Hello, everybody, and welcome to another episode of Figuring Out Fertility. My name is Carolyn Dubé. I'm the Executive Director with Fertility Matters Canada, and I am so excited today to be with Simon Phillips. He's the Scientific Director at Clinique Ovo and Procrea in Quebec, and we're going to talk about something that I am very excited about and that we see come up a lot through our support groups and in our social media, embryo grading and embryo development. So sort of that time period after egg retrieval. We're going to talk about what happens because a lot of us don't have information in that 3 to 5 day period. So Simon is actually also the president of the Canadian and Fertility and Andrology Society. They are the overarching body of fertility experts in Canada. So it's even more of an honor, Simon, for you to be here with us today. So I'd like to hand it over to you to tell us a little bit about yourself, and then we'll get into the discussion.
Thank you, Karen, and thank you very much for the opportunity to speak today and hopefully answer some questions for everybody. So as you mentioned, I'm an embryologist by training. I'm currently scientific director of the clinics in Quebec, of OVO and Procrea under the TFP kind of flag. So I've been an embryologist for over 25 years. I started my career in the UK. I moved to Canada in 1997, where I worked at McGill before starting OVO in 2003. And I've been involved in the CFES, as you mentioned too, for many, many years. And currently sitting on the board, and this year I have the honor of being the president. So I like to be involved in all aspects of fertility, and obviously this is a critical area where we are able to reach out to the patients who are the most important part of the whole process. So hopefully, you're going to ask me some questions. I'll try my best to answer them, and we'll see if we can clear some things up.
Wonderful. And I know, Simon, this is something you use with patients at Procrea and OVO. Now you do patient sort of counseling, is that correct? When you talk about some of these things with them?
Yeah, so we offer, at OVO, we offer a service where patients can meet the embryologist, so that's usually me, and we can run through some of the questions that might arise. So either patients who need a little bit more planning coming through their cycle, or otherwise when we're reviewing cycles that we might want to look at something that happened, if there's something that we can change from the lab point of view. Because obviously in fertility treatment, we have the clinical aspect, which is driven by the doctors, the REIs, and we have the lab aspect, which is driven by the embryologist. And the two work very well and integrated together. It's a pretty unusual field of medicine that we have those two parts, and neither one of them can operate without the other. So the best setup is where everyone works together.
Agreed. And I must mention that it is Canadian Infertility Awareness Week. And so this information and this series and this special interview today is part of our 2022 series on finding your joy and finding the joy along the fertility journey. And I feel like some of the things we could talk about today, a lot of the fertility journey, of course, is not full of joy. There's a lot of heavy, emotionally laden aspects for patients and for those who are seeking care. But I'm hopeful that maybe we can look at some of the things you talk about and finding the joy and getting your day 5 embryo grading, maybe a moment of joy on your fertility journey, as small or as big as that may be. So welcome to everybody who's here. We're really excited to get into this topic with Simon today. This is Canadian Infertility Awareness Week 2022, presented by Ferring Canada. So Simon, let's talk a little bit about, let's talk about what happens to the egg once it leaves the patient's body. So I feel that as patients, we have a very tight schedule when we enter fertility treatment. We know daily schedules right down to the minute or the second that we are injecting, and these eggs are growing, and then we go to our embryo transfer and we have our egg retrieval, and then we kind of go into this cone of silence or darkness for 3 to 5 days, where there's sort of nothing. To the patient, it feels very strange because um, there's nothing happening on our side, but there's a lot happening in the lab. So after egg retrieval, from sort of the moment the egg comes out, tell us a little bit about what happens in that process in the procedure.
Okay, so that's obviously very important, and maybe I can share some visuals which will help us to answer the question. So I'm just going to share my screen, and I'll ask you just to let me know if you can see an image up there.
Coming up now.
Taking a little time, maybe.
Yeah, that's okay. It's taking time on this side too, but that's okay.
Okay, so in the meantime, before that pops up, let's just talk a little bit about the idea that for the lab, the what we call the days changes a little bit of the egg collection. So as a patient, you've been going through everything based on your cycle. So day 1 of your period, and then injections through a certain number of days, and ultrasounds maybe on day 6, and ultrasound on day 9, and so on. When we get to the lab, we reset the clock. And for the lab and the embryologist, the egg collection day, we call it day 0. And that's really because from our point of view, the embryos are going to start their journey from there. And that's the important part from the embryologist. So we're going to start retiming. So sometimes we talk to patients about day 1 and day 2, and it gets a little confusing because as a patient going through fertility, your day 1 and your day 2 is completely different from an embryologist's point of view. So I think that's the first thing to mention. And we have a little diagram here for the egg collection. And so where we're retrieving the eggs in the follicular fluid, and that's taking place on day 0, as we say. But day 0 is also a very busy and important day in the laboratory because there's a lot of things going on. Not only are we retrieving the eggs, but we're also processing whatever the sperm source might be. We have to make sure we've got sperm and that it's ready to be used to fertilize the eggs. Okay, and then we've obviously got 2 ways that we could fertilize the eggs. So probably most people are familiar with this, but we have a traditional insemination method whereby we have prepared sperm and we have the eggs and we simply mix them together and we let them get on with it on their own, if you like. So during the night, we leave them together and then the next day we'll see whether they're fertilized. That's what we call standard insemination or standard IVF, and that's where the original IVF comes from. And the other method, which is used more and more often and is applied in certain cases specifically if there's a problem, let's say, on the male side that the sperm aren't very many and or they don't move very well. So they're not going to fertilize on their own in the traditional way, and we have to inject them, which is what we call ICSI. So it's a micro-injection technique that we can see in the picture here. So the sperm is being injected inside. The 2 methods, the idea is exactly the same. It's to create fertilization. There isn't one that's better than other if they're compared in an absolutely equal way. So we would apply one or the other depending on the patient's specific history and diagnostic tests and so on. So that's day 0, all of those things. And now often you would be told on day 0 after your egg collection maybe how many eggs you have. Then we've got to remember that from that number of eggs, not all of them will be mature. So it's only mature eggs that can fertilize. And when we do IVF, we usually see eggs in maybe 3 stages of maturation. And it's the ones in the final stage that we're interested in. So those are the ones that can result in a fertilization. And so the next day after the egg collection, so now we're on day 1, the embryologist is going to look at those eggs and is going to see have they fertilized or not. And if we look at the picture here, this is an egg which is fertilized. And if we look in the middle, we can see these 2 large circles. Those are what we call pronuclei. And the pronuclei are basically representative, one of the sperm and one of the egg. And it shows us that the egg is normally fertilized and doing what it should be doing at this point. So often, most clinics, somebody will call you on day 1 and tell you, okay, from your eggs from yesterday, we now have so many that are fertilized. And that's what they're talking about. We've seen so many eggs that look like this picture does.
Right. I have a question. Can I ask a question about it? Quite often we'll see questions come in from patients who have had a certain amount of eggs retrieved, and then not all of those eggs will necessarily fertilize. Is there a rate, or is there an average fertilization of these eggs, or is it completely dependent on each patient?
So that's a great question. Um, One of the things that we can talk about is the rate of attrition that occurs, because the number of eggs we start with is certainly not what we mostly are going to end up with a week later. And this is one of the most important steps. So there is, in general, the average fertilization rate is going to be around 70%. So 70 to 75. It, of course, is affected by different factors. So the eggs can affect it in terms of quality. The sperm can affect it in terms of their quality. So there are various factors that could cause it to be lower than that or potentially higher. But if we look in general, we're looking about 3/4 of those eggs that are mature, that we talked about a minute ago, that could and would probably fertilize.
Right. Is there a sort of a sweet spot for the number of eggs? Do reproductive endocrinologists and embryologists, they say if we can get an average of X amount of eggs, sort of by attrition by day 5, we should have, 1 or 2 or 3 embryos left for transfer. That might be an impossible question. I'm just curious to know if there's a sort of a number. Or are there too many
I'm not
eggs?
sure that there's too many eggs. Yeah, um, those are really good questions. I'm not sure there's a magic number. For sure, one thing I can say is in the time that I've been working in the field, we've certainly come down to the point where we are trying maybe not to get quite so many as we used to, with the concept of rather having less that are more competent. Let's say less is more in this circumstance. But I would say on average, at least in the clinics that I'm involved in, we're probably on average picking up around 12 eggs from across the board. But of course, there are factors that influence that dramatically. So a patient whose ovaries are already what we would call with a low ovarian reserve, so their ability to produce eggs is dropped, maybe not reach that point. And then there are patients as well who have polycystic ovaries who would tend to produce more, and sometimes a lot more than that. And that's not necessarily a bad situation either. So I don't think we should get too hung up on the number, because you can have a patient with a lot of eggs which are very good. You can have a patient with a lot of eggs which are not so good. So it really comes down to the specific case.
Yeah, thank you for clarifying that. And I think that that's really important information, almost setting expectations with patients prior to egg retrieval. And of course, based on it's on a very specific patient case by case basis. But I think setting expectations like that is really important. And sometimes if expectations of the patient are different than the expectations of the clinician, that probably could cause some frustration on the patient side. Only because their expectations may have been off from what clinically would be best case scenario for them.
For sure. And of course, the physician is going to adjust the protocol that's used to stimulate the ovaries depending on whether there's a low reserve or a higher reserve. We're not going to stimulate a high reserve with a lot of medication, with the risk that it gets kind of out of control, if you like. And on the other hand, you need to push ovaries with less, maybe a little bit harder, to try and make sure we get as many as possible. So your REI should be explaining the reason why the medications are like that, but that's often going to be the case. It'll be moderated based on that to try and optimize the return. So to get somewhere in the middle.
Wonderful. Thank you for that. I'm sorry, I just wanted to jump in because I feel like there's some of those clarifying pieces for patients will be really important.
Yeah, that's great. Thank you for that. So if we go back to our pictures again, we were talking about day 1 and fertilization. And then the next day, and usually actually by the end of day 1, so some clinics may look at the end of day 1, but mostly they'll be looking early on day 2, the embryo should have divided. So if they fertilize normally, most embryos that fertilize normally or eggs that fertilize normally will divide. Okay, we were talking about percentages before. Here we're talking about close to 100%. So there's not usually a drop off between day 1 and day 2, unless there's some particular factor which is playing a role in that patient's fertility-like situation. So, and what we're looking for on day 2, if we look at this picture, is the number of cells. And you can see in that picture probably that we've got 4 cells. And then we're going to look at the quality. And so people will have slightly different scoring systems in different clinics. So I'll try and speak generically. But in general, most scoring systems of embryos on day 2 and day 3 are based on the number of cells and then the grade of those cells. So if we look at this embryo, it has 4 cells, 1, 2, 3, 4. And so most systems would be something like 4C1 or 4C2. And that would mean, for example, that we've got a 4-cell embryo. So the 4C is 4 cells. And then we've got a grade 1, 2, 3 is the most classic one, but you could have 1 to 4. You could grade like A, B, C, D, or 4, 3, 2, 1. So that can be dependent on the clinic, but usually something like that. And the grading of the embryo is going to be based on different factors. So in fact, if we look at this one again, this is a really nice embryo, obviously, because they used it in the brochure. And so we've got 4 cells. The 4 cells are pretty much the same size. We can see that. That's a good thing. The 4 cells are quite clear as well. You can see the cells underneath through the cells on the top. So that's usually a good thing. And there's very little material or cytoplasm which is broken off when the cells divide, which is what we would call fragmentation or cellular debris. So sometimes when a cell divides, instead of all the material remaining in the 2 daughter cells, we get little pieces of material that come off, and that creates fragmentation. It's actually very common in human embryos. As long as it isn't too excessive, then we wouldn't consider it being too big an issue. But as it gets more important, then it can have a factor in terms of the quality of and the potential of that embryo. Okay. So depending on the clinic too, you may get called on that day and told what's going on. And other clinics maybe don't communicate each day. So that's going to be different as to where it goes. So in our clinics, we would speak on day 1 and on day 2. We wouldn't, however, speak to you in general on day 3 and day 4. Now, the reason for that is we've got very fast divisions going on those 2 days. On day 3, we should be up to sort of 8 to 12 cells. So the embryo is dividing. We're still going to use a scoring system like the one that we were just talking about. And then on day 4, we get very rapid division and what looks like the cells all kind of merging together into a big blob. So if we look at this embryo here, this is called a morula. It's actually very difficult to score because, as you can see, the lines between the cells are kind of merged because the cells are what we call compacting. And so the cells are all coming together. And really, I mean, it doesn't sound very pretty, but it does look a little bit like a big blob. So this is actually a very nice morula. Now, when I mentioned before about maybe not looking or calling on these days, often now, many clinics won't even score your embryos on these days. And the reason is because they're very critical steps in the embryo's development. And because they're critical, our preference is to leave the embryos alone during those specific times. So some clinics will still check and other ones have moved away from that. So depending on which clinic you're in, you may or may not get a call on those days. And the reason is this: if we go right back to the beginning of the story, we know that when the egg fertilized, the sperm had a role to play, had to be present, it had to cause the fertilization, and then the egg kind of takes over. And so from the beginning to around here, it's actually the egg doing all the work. So the sperm is kind of done its role and now it's sitting back a little bit. The egg drives the first divisions all on its own. And that actually is quite a useful information for post-cycle when we're reviewing a cycle, because if we see problems earlier on, it's often an indication more on the egg side. And if we see a problem later on, it's more a problem sperm in general. See, it's very rare. And so that means that on day 3 and day 4, that's when for the first time, the 2 sides are working together and therefore obviously very critical. And that's why we tend to leave them be for those days.
That's fascinating.
That's also one of the reasons why the goal of this process is well, the original goal, the goal of is obviously a baby, but at this point, the goal is to get blastocysts. And the reason why we go to blastocysts now, and we used to do our embryo transfers much earlier on day 3 and sometimes even on day 2. The reason we go to blastocysts now is because these 2 days provide the most natural selection. And that's because most embryos will grow, as we said, day 2, probably day 3. They might start to show a bit of quality change, but they'll mostly grow. But we're going to get embryos that stop growing between day 3 and day 5. And so now we're really getting some great natural selection. Natural selection helps us to increase the pregnancy rate and reduce the number of unnecessary transfers.
Right. Again, this information is, I think a lot of patients will not have had this kind of quality information. And not because they haven't heard it, but sometimes when you're hearing it in a quick phone call or when you're sitting down with your physician, you can't process it all. So I think that this is fascinating for patients. I think everybody's going to be so grateful for the information you're providing.
Please, I certainly hope that it can help. You're absolutely right. Like for me, these kind of words and concepts are obviously very natural, but I can understand, and we do understand in the lab, that for people who have maybe no scientific background at all, when we talk about blastocysts and cleavage and these kind of things, it just means absolutely nothing. So it's perfectly understandable. And I would also I suggest that people have questions, they should ask to speak to the embryologist. The embryologists in general are very happy to talk about embryos. You know, they live their life around them, and they're very happy to talk about them. So in general, I would think that that's, it's a good idea to ask those questions.
And the embryologists play a very special role. They're your baby's first babysitter. Truly, this is something that's very special. What you do and what the embryologists do is an incredible job. And I think that highlighting that piece of the journey is really important. So thank you. I do have a question, and this is just purely for my own personal curiosity. When we know that this rapid cell division is happening, like what is rapid? What is the sort of time frame for cell division? Is there an average?
Oh yeah, that's a great question. So let's say on day 2, we're looking around 4 cells. On day 3, we're looking around 8 to 10. By the blastocyst, we're over 100.
Okay.
Okay, so, and obviously the more cells, it becomes exponential anyway. So it's kind of normal that it goes over these days. But we're really talking about something completely different on day 5 with a blastocyst in terms of numbers of cells than we were talking about earlier.
Okay, great. That's really good information.
Actually leads us into the fact that blastocysts are scored completely differently. And that's one of the reasons. We can't really sit there and count all those cells because that wouldn't go down very well, and it wouldn't really help us either. So probably people have heard of blastocyst scoring, and they'll have heard something like 3AB and things like that. So this is a system which is called the Gardner System. It's based on a system that David Gardner published many, many years ago. And it basically uses a number and then 2 letters. And the number may vary because there are 2 versions of the Gardner System. So the number either does 1 to 4 or 1 to 6. Now, basically what the number means is how much the embryo has expanded. And by that, what we're talking about is, if we look in the picture, initially when we reach a blastocyst, its actual size is the same as the egg, because the egg size hasn't changed as the embryo changed, just the cells got smaller. So the volume is the same. Once we get to a blastocyst, we end up with 3 elements to create the blastocyst. In this picture, we have a group of cells here at kind of 10, 11 o'clock. That's what we call the inner cell mass. We have a group of cells which go around the outside of the embryo. That's the trifectodome. And we have a blastocele, which is the liquid in the middle here, the cavity. Those are the 3 elements we need for it to be a blastocyst. And what actually happens at that point is we have a blastocyst here, which is the same size as it was all the way along. What's going to happen is those trophectoderm cells are going to pull fluid in to the cavity. The cavity is going to get bigger, and the blastocyst is going to expand. Eventually, when it's big enough in its expansion, it's actually going to break its shell, for want of a better word, and then it will actually hatch. So I know this sounds like we're talking about chickens, but we're not. This is exactly what happens with the blastocyst, and it will actually hatch out of its shell or its wall. We call it the zona, and then that's when it's actually able to implant. It can't implant at the moment because it has a shell around the outside. Okay, so the 1, 2, 3, 4 in the scale basically tells us how big it's expanded. So this would be a 1 because it hasn't started, and by the time it gets to 4, it's actually coming out of its shell.
Right. Now, when you transfer a hatching, I've seen that before. Some of them are hatching. When you get to transfer day, you're transferring one that's hatching. Is transferring a hatching embryo more advantageous than transferring one that has not hatched?
Not necessarily.
Okay.
It's probably more a question of time.
Okay.
If your embryo transfer is a little later, more likely that the embryo is a little bit more advanced. But a lot of this is down to time. So we're talking about days here, but the embryos obviously don't know which day it is. They're actually interested in hours post things happening. So if your egg collection takes place later in the day because it was a busy day, and your embryo transfer is slightly earlier, well, it's probable that the blastocyst will be less developed, and the other way around.
Right.
Yeah.
That makes complete sense.
The more important things, honestly, are the 2 letters. So the A, B, C, and the ABC. And the reason is because they relate to the actual contents of the embryo. So we talked about the 2 regions here, the inner cell mass and the trophectoderm cells. Each one of those is represented by a letter. So say the A or the B or the C. And the reason being, A would mean that we have plenty of cells in that body of group of cells, and they're closely tied together, and they're forming a good kind of network, if you like. And that applies in both cases. So this and this. Now, the first group is the inner cell mass. This is actually what's going to become the fetus. And the trophectoderm cells is what's going to become the placenta. So if we were to score this embryo, as I said, it's probably a 1. It may be a 2. It's beginning to go a little bit bigger. It has very nice cells in both the inner cell mass and in the trophectoderm. So it would probably be, we could say something like a 2AA. Okay. Now, if we had a 2AA, a 3AA, a 4AA, something like that, that's obviously a really nice embryo. It's going to have very good potential. And if we start to see embryos which have lower grading, then obviously their potential is less. And clinics will use that to determine what their cutoff is. So we can sometimes reach blastocysts, but we can have a call to say, well, the embryo isn't transferable, it's not freezable. And that's because there isn't sufficient cells in one or other of those areas that we can actually achieve an ongoing pregnancy. So there isn't any use in trying with that embryo. Okay. So sometimes we won't make blastocysts, and sometimes we'll make an unusable blastocyst, if you like. And obviously, what we want is usable blastocysts. Usable blastocysts would be the ones that would be graded by the clinic sufficient to be used either to freeze or to transfer fresh.
Great. And the attrition rate after sort of between day 3 and 5, is there a significant average drop off after day 3, or what do you typically see?
That's going to vary a little bit lab to lab, but what we would want to see is at least 50% development from there. So usually when I see patients and talking to them before their cycle, the kind of number I say to keep in mind, if you add all the things together, is your number of eggs to your number of blastocysts at the end, it's about a third.
Okay, that's really helpful.
If you have the 10 to 12 egg average that we talked about a few minutes ago, and we end up with 3 or 4 blastocysts, we should be very happy with the cycle.
That's great. And again, I think that that's just important. Again, setting expectation of we have 10, we should expect 3, maybe 4. That would be successful.
Yeah, exactly. And you're right, it's a very important thing because it's not unusual for me to talk to people who are very surprised that, well, I had 20 eggs and I've only got 5. That's actually okay. You know, we shouldn't be too disappointed with that. It may be on the low end of the range, but it's okay still. And it's because there is a rate of attrition, and it seems great on day 1 when we had 20 eggs or 15 eggs, and then 5 days later when we have however many we have, but it could still be, you know, a very good outcome. And at the end of the day, it only takes 1.
Right.
So what we're dealing with here is very high potential embryos. We're not talking about embryos back on day 3 where their potential is much slower. If we're talking about blastocysts and we say it's a good quality blastocyst, given all the other parameters which play a role in achieving a pregnancy, then we're talking about something with great potential.
Yeah, and that's really important. And I think, you know, it feels like panicky when you, from the patient perspective, to think, gosh, how did I go from having so many to, it feels like almost nothing at that point. But you're right. It's the quality of these embryos that would potentially be able to turn into, to develop into a baby versus something that didn't have the potential to begin with.
Right.
Great.
Maybe I can stop showing that so I can see you better. But
Yeah.
one thing maybe that I would add is there's sometimes the discussion whether we do transfers on day 3 versus day 5. And obviously, this is an interesting question. We didn't used to go past day 2 or day 3 because we just didn't have the capacity in the labs to grow those critical phases. But for quite a few years now, you know, at least over 10 years, the labs are capable. They have the equipment, the incubators. We have the culture media systems, which are capable of growing the embryos. And so some people will ask me, okay, well, I did my cycle and I didn't end up with any blastocysts. And as you say, it's important to manage expectations. And sometimes I think it's important to look at what happens if it's the worst case situation, like how are we going to approach that? Now, there's obviously an argument that if you had nice embryos on day 3 and they were transferred, would the uterus have performed better than the lab? Now, I can't say for every lab in the world that the lab would have performed equally to a uterus, but there are factors that we have to take into consideration. One of them is that an embryo on day 3 naturally isn't found in the uterus. It's still in the tube. So we're not actually putting it in the place it wants to be, even if we're putting it naturally, if you like. And so my personal feeling, and it's totally my personal feeling, is that we gain a lot more by going to day 5, even on those rare occasions where there isn't anything to transfer. What we've done is that we've avoided a transfer that could have produced hope and then disappointment. And we've saved a little bit of time by not doing that transfer. So now we've got a little bit more time to discuss together, what can we do as the next step? Can we make it better? Which direction are we going to go in? So I would see that as the positive, even in a very, very difficult situation.
Of course. And you know, that's the reality is it is a difficult situation. So the conversations are more challenging, and we know and patients know that clinicians are making these decisions based on clinical best practice and for the optimal health outcome of the patient for sure. Yeah. I do have a question about the scoring of the embryos. Is there a technique? I believe that most of them are currently scored sort of visually by the embryologist. You sort of use your eyes and score them manually, for lack of a better term. And is there, or do you see a time in the future where these will be graded? Because I assume that I don't mean error, but how you grade an embryo versus how another embryologist would grade an embryo could be slightly different. Do you see the future with tech in embryology having a device to more accurately provide a score to embryos?
Yeah, I think for sure that's something that's doable. Your point is very true that we know that probably in a lab the scoring is pretty similar because embryologists work together and sometimes they'll look at the same embryo and come up with an idea between them as to what they would score it at. But yeah, if we start comparing lab to lab, we know that we do see differences, slight differences. There's already some tech which is available. If we talk about time lapse technology where the embryos go or the eggs go in an incubator and don't come out because there's a camera in there. So the camera is taking pictures all the time instead of the embryologist taking it out. Those systems allow us to add on morphokinetics, which is the timing of events. So not just seeing that an embryo is 4 cells and now it's 8 cells, but what time was it 4 cells? What time was it 8 cells? Because those are also factors which help us determine the competency of an embryo. And some of those time-lapse systems actually have AI-driven algorithms in them help to determine some of those factors. So there's an increasing amount of AI technology, as I'm sure you're aware, that's gradually creeping into IVF. It's not by any means well proven as yet, but it's certainly, I think, in the next few years, we're going to see ways of determining the embryo's quality better than just looking at it down the microscope.
Amazing. And I mean, I feel like fertility is such a new, or fertility treatment specifically is such a new area of medicine in the global scale of medical technology, even though it's 40 something years old, I suppose. And I feel even in the time I've been in the industry, 7 years, I've seen so many advancements on the tech side to help streamline and improve patient outcome, and what's allowing people to down the path of taking home a baby. So I'm excited to watch the future of this piece because I feel that there's many opportunities for advancements in this really young field of medicine.
Yeah, you're absolutely right. It's very fast moving, and there certainly are technologies which are already beginning to be used.
Yeah, definitely. So Simon, I think that we've got a good, really good, and I can't believe how much I actually learned today. I thought I knew a lot, but I have certainly taken some tidbits of, from retrieval to the day 0 through day 5, what's happening on those sort of more critical days of 3 and 4, and why we choose to transfer on day 5 versus day 3 as in the past. You have really, I think you did a great job of explaining that. And I feel like a lot of people are going to get a lot of good takeaways using the information you're giving today. Are there things that we haven't talked about that you think are important for people to consider?
Well, one thing I think maybe we should just quickly mention is we were talking about Blastocyst in day 5. It's important to understand that sometimes the Blastocyst will develop on day 6.
Oh, yes.
And occasionally we'll even keep going to day 7, especially in patients where we're doing genetic testing in the same time. So for those patients, often many clinics will keep going an extra day, but pretty much always day 5 and day 6. Blastocysts developing on day 6 are fine, okay, as well. So we can do day 5 and day 6. We generally don't do the fresh transfers on day 6. The reason for that is if we're planning a fresh transfer, so a patient planning a fresh transfer is taking medication to make sure her uterus is progressing as it should, and the endometrium is ready. If the embryo develops on day 6, it's out of sync with the uterus. So now the uterus is a little bit ahead of embryo, and we know that there's a window of implantation that exists. So sometimes it may be determined, depending on the clinic and their protocol, obviously, that we're not going to fresh transfer day 6. We certainly do that in our clinic. And that's because we don't want to make sure we hit that window of implantation. So we're better off freezing it.
Yeah.
And then in another cycle, we'll realign everything and we'll make sure that the embryo is going back right in the middle of the window of implantation.
Okay. So when you move to an FET with a day 6 embryo, does that make how you line things up from a day 5 embryo or a day versus a day 6 embryo during an FET. Are those different or are they the same? It's just that now we line things up a little different. Like, would the embryologist or physician need to know that this is a day 6 embryo we're transferring and that changes someone's protocol?
Yeah, so again, depending on the protocol of the clinics, because clinics will have slightly different protocols, there may be a slight change to when
Okay.
the thawing takes place. But in general, you're going to use that opportunity to correct the little misalignment. So the thawing will take place at a point where you make sure that the day 6, whether it's a day 6 or a day 5, it's going back at the right point in terms of the endometrium development.
Okay. Okay. That's really important to know. I think that that's really fascinating because I've certainly seen patients question, well, it's developing on day 6 and I have to freeze it or freeze my embryos on day 6. I would love to, why couldn't I just transfer it today? So that's really helpful. Great.
Yeah.
Wow. So I know that this information is going to be it will be so well received. It is critical information, I think. And as I mentioned before, it's not because patients aren't necessarily getting this information from their REIs or embryologists at the clinic, but sometimes when you're in the sort of throes of everything, computing what's happening and getting a real understanding of what you're seeing and what you're hearing, when you expand it out like you did today, I think will be incredibly helpful. I probably should put together a little print off for people to be able to download or share on social media so they can get a really good understanding of what's happening.
Well, I certainly hope that it helped. And maybe if people have questions and they send them in to you, then we can find a way to answer those
Absolutely.
questions.
That would be great. Simon, thank you so much for your time today. It's incredibly important for experts in the field to share their knowledge so that all Canadians who need to access fertility care can feel more educated or more empowered to make these very difficult decisions sometimes. And sometimes hearing the information like this helps make certainly decisions easier. It kind of clears your conscience sometimes on hard decisions that you do have to make as a patient. And also, we hope that information like this makes the job of the clinicians easier because your patients are coming in more educated. They're asking more questions. They feel more confident asking questions because they have a bit more knowledge. So truly, your time is so appreciated today. Thank you for your continued support of of Fertility Matters. Of course, to the CFAS for your continued work with them to ensure that Canada remains a leader in fertility care. And for everybody watching today, we hope that you are enjoying Canadian Infertility Awareness Week 2022. We appreciate you being here. Please visit ciaw.ca, and we hope that you certainly are finding your joy this April. Please, for more information or for support and education, visit fertilitymatters.ca. And a huge thanks to our presenting sponsor, Ferring Pharmaceuticals.